All right, I think we'll go ahead and get started. Welcome, everyone. My name is Dr. Rob Murphy, and I'm the Executive Director of the Havey Institute for Global Health, and John Philip Thayer, Professor of Infectious Diseases and Professor of Biomedical Engineering here at Northwestern University's Feinberg School of Medicine. Thank you very much for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health seminar series. Hosted in partnership this time with the Ryan Family Center for Global Primary Care. The title today is Think Global, Act Local, Harnessing Implementation Science to Address Non-Communicable Diseases. I'm joined today by our co-host, Lisa Hirschhorn. She's the director of the Ryan Family Center for Global Primary Care, and she's going to be leading the question and answer discussion after the presentation today. Please take a moment to follow us on LinkedIn and Facebook, as well as Blue Sky, Instagram at FSM Global Health. In addition, we welcome you to become an Institute member, and you'll receive access to specialized resources and services that support research infrastructure. For more information, please visit our website at, very simple, globalhealth.northwestern.edu/members. The Havey Institute for Global Health and the Ryan Family Center for Global Primary Care are thrilled today to host our Post-Doctoral Scholar, Dr. Chisom Obiezu-Umeh. Dr. Obiezu-Umeh is a postdoctoral research fellow here at Northwestern University's Feinberg School of Medicine. Her work focuses on implementation science and global health with an emphasis on advancing community-to-clinic interventions to address chronic disease disparities in resource-constrained settings. She has expertise in community-engaged research, social innovation, and the development and psychometric evaluation of measurement tools. We welcome you to submit questions. Please use the Q&A feature listed at the bottom right-hand corner of your screen at any time during the presentation. And as I said, Dr. Hirschhorn will be leading the question and answer discussion following the presentation. And now, Dr. Obiezu-Umeh, I turn it over to you. We welcome you, and we look forward to hearing your presentation.
Great. Thank you so much, Dr. Murphy, for the wonderful introduction. I'm going to go ahead and set this up and set up my slides, and you can let me know if it's the right view.
Yeah, it's there. You can put it in the presentation mode. Yeah.
Okay. Awesome. Just make sure. Okay. Wonderful. So hello. Thank you so much. So hello, everyone. It's a great pleasure to give this lecture today about the concept of thinking globally and acting locally. How can we leverage implementation science to address the growing burden of NCDs? So for this lecture, here are three main areas I'll be covering today, with some time left at the end, towards the end, for Q&A. So first, I will provide background on the global landscape of NCDs and key implementation science concepts. And then next, I will introduce the idea of reciprocal innovation and how it has been applied across high-income countries and low and middle-income countries. And then finally, I'll close with some final reflections. So let's start with this simple question: what are NCDs? These are non-communicable diseases are long-term conditions that are not passed from persons to persons. They often share common risk factors like tobacco use, unhealthy diets, physical inactivity, harmful alcohol use, and air pollution. So many people live with more than one NCDs at the same time. Now, these conditions don't just drive premature mortality, they also significantly reduce quality of life in general. And then the big fives that we often or typically focus on are cardiovascular disease, cancer, lung disease, diabetes, and mental health conditions. So the global NCD burden has steadily increased over the years, as you can see in the figure, from 1990 to 2001, such that in 2001, NCD actually accounted for 43.8 million deaths and 1.7 billion disability-adjusted life years, which reflects the total number of healthy years of life lost across populations. Now, cardiovascular disease makes up the largest share of this burden, as you can see on the graph, which will be the main focus of my presentation in today's lecture. And also, I wanted to note that the premature mortality rates from NCDs are much higher in low middle income countries, which I would call LMICs for the rest of the lecture, and high income countries. So one major concern is the increasing and uneven burden of cardiovascular diseases in LMICs. So more than 75% of global CVD burden is concentrated in LMICs, especially in regions such as Sub-Saharan Africa and East and South Asia. So at the same time, disparities also exist in high-income countries. So let's take US for an example. Rural populations experience worse outcomes across a range of cardiovascular diseases, including stroke and heart failure. So all in all, we are on this journey towards reaching or achieving the global goal of reducing premature mortality, excuse me, from premature mortality from NCDs by 30% by the year 2030. So you might ask then, given that there's this global NCD crisis that affects both mortality and morbidity, do we have the prevention and treatment options needed to address the growing demand? And the resounding answer is yes. But the truth is, we will remain far from achieving this goal unless we really invest in implementing this prevention and treatment strategies effectively. So then the natural question then becomes, if we know what works, why aren't folks doing it? The reality is that barriers exist, such as limited funding, insufficient capacity and infrastructure, and fragmented health systems. These challenges oftentimes create what we call the no-do gap. So the gap between what we know works and what actually happens in clinical settings. This gap not only prevents life-saving treatments from reaching those who are in need of them, but it also delays implementation of critical health interventions. You may have heard this staggering statistics, which is a very common one. On average, it takes 17 years for evidence to translate into practice. And even then, only 14% of research ever make that leap, meaning that very little research will make very little public health impact, and most of it would not even get used. But then the good news is we can address this, right? Implementation science provides the tools and strategies to bridge that no-do gap and ultimately improve clinical care. So then what is implementation science? So to orient us and put simply, implementation science is about helping people and places do the thing. So helping people and places do the things that work, do the things that work. So you can think of this as helping to bring all the puzzle pieces together. So more formally, the NIH definition of implementation science is the study of methods to promote the adoption and integration of effective practices and interventions and policy into routine healthcare and public health settings, ultimately to improve the impact on population health. So now let's go over some key implementation science terms in a more simplified way. The intervention or practice or innovation that improves people's health is what we call the thing. Implementation is the act of doing the thing. And then effectiveness research, which is the typical or the traditional forms of research, looks at whether the thing works. Implementation research, on the other hand, looks at how to help others do the thing. Then implementation determinants, which we also call contexts, are those conditions that might make it harder or easier for others to do the thing, which you might oftentimes see as barriers and facilitators. Then implementation strategies are those actions that we take to help others do the thing. And then lastly, implementation outcomes are how much, how well, and how equitably others do the thing. So to lay this all out simply, first there has to be an evidence-based thing, so your what's. Now, implementation strategies involves figuring out how best to implement the thing. This is really the core of implementation science. is really the core of implementation science. But for this lecture, I also want to call out that the implementation strategy in particular. So over the course of this talk, I will walk you through examples of strategies used to deliver NCDs. And like I mentioned, the core of implementation science is to really develop and design and test those strategies to implement what we know works. And then lastly, the outcomes we look at go beyond the typical effectiveness or patient-level outcomes. So we oftentimes would examine whether the delivery of the intervention is feasible or sustainable and at what cost. So often I get asked, so now, is my research question an implementation science question? So one useful way to really think this through or lay it all out is this implementation science subway line, which helps to map out where you are with your work. You usually start with a practice of interest. So let's take hypertension medication or BP lowering medication as an example. So let's say that's our evidence-based thing. On the red line, we asked, has this treatment shown efficacy? Is it efficacious? That is, it's oftentimes, does it work in tightly controlled environments? So now, if your answer is no, the focus should then be on developing the treatment itself with an eye for implementation science. But if your answer is yes, which it is in this case for hypertension medication, so the next step is the yellow line, which is then asking, has the treatment shown effectiveness in the real world? Here we evaluate how well the intervention performs in your typical practice setting. If effectiveness hasn't been shown, you might want to then conduct what we call the pragmatic trials in clinics to measure your typical patient-level outcomes. But that by itself is actually not implementation science. Where implementation science really comes in is the green line, which are the ones in the stars. What we call the hybrid trial design. And this is where we focus on really understanding implementation processes. And this is where we spend most of our time as implementation scientists. So a quick shout out to Amy, Densley, and Zabine for this great IS slides. But now in thinking about the big picture on how implementation science can help us achieve population impact, let's look at this more qualitatively. So imagine an innovation that is 100% effective in controlled setting, like blood pressure lowering medication. So under the perfect condition, in theory, we could achieve 100% impact. But we know that that's not how it works in the real world. Perhaps only 50% of clinics choose to offer BP lowering medication. Then only 50% of providers follow the protocol on administering this medication. Then only 50% of those providers offer these medications to the patients. And then only 50% of those patients use it. And with all of this, only 50% of clinics continue to offer BP lowering medication over time, which will then lead to a significantly lower population impact. And this is where implementation science comes in. It helps us to understand what's really happening along the way. You might have heard the saying that context is king, and the implementation science emphasize on it. It has strong emphasis on how context influence delivery of these strategies and how we can improve the way it's being delivered along the way to ultimately maximize population level impact. Now let's talk about reciprocal innovations and how it's been applied in implementation research. Using hypertension care as an example, so several barriers exist across multiple levels, many of which are shared across LMICs and high-income countries. At the patient level, for example, so challenges include low health literacy, poor medication adherence, high treatment cost, and at the provider level, there's often limited capacity and training to deliver hypertension care. And then at the health system level, there's oftentimes fragmentation in care, which could affect efficiency of how services are being delivered at those clinics. However, evidence-based practices from high-income countries can actually be adapted to guide health systems reform and improve hypertension care in LMICs and vice versa. And this brings us to the concept of what we call reciprocal innovation. or learning, which is formally defined as a bidirectional and interactive exchange of ideas, resources, innovation to address a shared health challenge across diverse global settings. The key idea here is that shared challenges between high income and low income creates opportunities to share solutions that we know works and then implement them. This exchange goes both ways, I would emphasize. So from high income to low income countries, but also from rural regions to urban regions and across countries. And I'll give examples of that as I move along. The major emphasis here is on localizing, so adapting interventions to fit specific local context, which is the central theme of implementation science. So the question becomes, how is reciprocal innovation already improving NCDs, specifically hypertension? This is what I hope to answer throughout my presentation today. So let's look at hypertension care cascade, which corresponds to the prevalence, awareness, treatment, and control of hypertension. So now comparing a high-income country, the United States, with a low and middle-income country, Nigeria, this highlights the challenges across the cascade. So let's start with the US. About 69 million people are hypertensive, while awareness, treatment, control are somewhat better than many LMICs. It's still suboptimal, which shows that there's still a long way to go, and there's still a lot to be done to address the burden. Whereas in Nigeria, about 19 million people are hypertensive, and outcomes along the care cascade are also suboptimal. So this really shows that there's a strong need to intensify both prevention and treatment efforts across all board, both LMICs and high-income countries. So eliminating inequities in hypertension control requires multi-component, multi-level intervention that address a wide range of individual health system barriers that I discussed earlier. Two evidence-based implementation package, which is what I'll call it, really exemplifies this sort of approach. So let's start with the Kaiser bundle, which was originally developed in the US, in California to be specific, and has since been scaled to multiple regions in the US. So we know it works. Similarly, the WHO Hearts package parallels the Kaiser bundle and has demonstrated effectiveness in improving system-level hypertension outcomes, such as BP control, across many LMICs like Nigeria as well. So you can also see that there's similarities in both packages, such as the evidence-based treatment protocol, which is highlighted in red. Creating systems for monitoring performance and quality of care is also similar in both packages. So at this point, you might be wondering, well, this implementation packages already exist, but how do we actually ensure that clinics take them up and use them in routine care? So one key strategy is to integrate hypertension care packages, so the Hearts or the Kaiser, into primary healthcare settings. So PHC, for the rest of the presentation, I'm going to call this PHC to shorten it. So PHCs are the bedrock of the health systems. They provide the first contact, continuous, comprehensive, coordinated, and person-centered care in the community. However, hypertension care is often not routinely offered in PHCs, particularly in low-resource settings. So implementation science can really support the integration and delivery of hypertension care in PHCs, helping to bring care closer to the community and to reach more people. So let's look at the case of implementing the Kaiser bundle across 12 clinics within the San Francisco Health Network. Strategies that they implemented included a simplified treatment protocol, nurse and pharmacist-led BP visits, BP check visits, so BP being blood pressure, a hypertension patient registry to support adherence and monitoring of patients. And then this program was evaluated using the hybrid type 1 design, which allowed the team to evaluate both the effectiveness of the program on BP control and also to understand what's really going on. So understand the implementation processes over 24 months. So they found that more than 15,000, so they enrolled 15,000, over 15,000 patients with hypertension in the program. Over the course of the 24 months, they saw or they found significant improvements in blood pressure control, which increased from the 68% to the 78%, which is highlighted in the deep red line. Key factors that contributed to this success from their study included engagement of key partners within the health network, and they also engaged the original developers of the Kaiser program to inform the adaptation of the program. Also, there was a strong leadership support from the higher ups in the organization, and there was strong alignment with organizational quality improvement goals and priorities. And then lastly, blood pressure check visits that were led by non-physician healthcare workers. So this concept of task shifting or task sharing. Now let's look at another case, which is an R1 grant focused on implementing an adapted WHO package across 60 primary healthcare centers in the Federal Capital Territory of Nigeria. We applied a hybrid type 2 design, which allowed us to evaluate both implementation processes and effectiveness outcomes simultaneously. In addition to this, we adapted the original HAT strategies, which I mentioned earlier. And some of the adaptations we made based on the things, our formative work and the things that we're hearing on the ground, was that we needed to train community healthcare workers to manage hypertension at the primary care level, and not just giving them one-time training, but refresher trainings. We also initially, we also provided free medications initially, but later we transitioned to a reduced cost medication through what we call the drug revolving fund to enhance sustainability of demand and supply of the medication. We also organized quarterly community events or awareness outreach events at the local community to drive demands from the community to the clinic. And then lastly, we conducted quarterly supportive supervision visits to support community healthcare workers and the overall implementation. So the primary effectiveness outcome of this study, as you can see in the figure, shows the 6 months rolling average of BP control rates. So we're going to be looking at the deep dark line. So as you can see on the graph, overall blood pressure control increased from 21.7% in February of 2020 to 55.9% in December of 2023. So again, demonstrating that this program actually works and the strategies are effective. So taking a closer look, so what exactly is happening on the ground? So we did a mixed method study using the REAIM framework, a well-known implementation science framework, to evaluate implementation outcomes. Now we found higher reach with over 21,000 hypertensive patients enrolled, which makes it one of the largest of its kind in the region. There was also high adoption of the program's protocol and a strong evidence of normalization and sustainability in routine practice. So to better understand what drove these results, we looked at key factors that influenced them. To name a few, we found high acceptability overall among patients and community. They loved that we brought treatment closer to them, closer to the community. It was more accessible. We also found that we experienced minimal stockouts of medication due to the drug revolving fund that was implemented. And importantly, we had strong partner engagements with the ministries of health in Nigeria, which enabled the inclusion of the BP lowering medication in the National Health Insurance Scheme in Nigeria. So now, we have talked about integrating hypertension care in PHC. Now let's turn to integrating hypertension care within HIV care setting, and I'm going to hopefully answer the question why. With the dual burden of infectious and non-communicable disease, people living with HIV are now living longer, and aging in this population has led to the rise of co-occurring chronic conditions, which also creates a unique opportunity to leverage the successes and platforms of the HIV, what the HIV field has accomplished to really deliver hypertension care and other NCD care. So in practice, integrated care really means that managing people living with HIV and those with NCD comorbidities in the same facility and with the same clinical team or staff treating all condition. Again, making sure, breaking those silos. So this main message here is that we don't have to reinvent the wheel, right? When we can easily piggyback on lessons and strategies that has been successful in HIV services. So an example of this approach is the Intercare study in Botswana. And Botswana is recognized as a leader actually in the global space for their HIV efforts. So they've surpassed the UNAIDS 95 targets. The Intercare program applied successful HIV strategies to really deliver hypertension services in 2 infectious disease clinics in Botswana. Key components that they used were this adapted electronic health records to capture hypertension risk and treatments. They also conducted provided training on hypertension care and other NCD care as well, and CVD care as well. And then they engage community-based treatment partner to support adherence of their patients. So the program was then piloted using a hybrid type 2 design over the course of 24 months. So taking a closer look at the implementation process, they used a mixed method study, which was also conducted using REAIN framework and the CIFR framework to evaluate the overall implementation outcomes of the Intercare program. So key findings included that they had a high reach of the program. So a large number of patients were engaged throughout. They enrolled 209 people living with HIV. And then there was high effectiveness on blood pressure control. So it improved from 47.2% to 71%. There was also high fidelity. So treatment partners really adhered closely to the protocol. And then lastly, there was low adoption of the EHR, which was partly attributed to the fact that there were power outages and limited hypertension medication options within the EHR system. Here are the qualitative findings, which I'm not going to go into details, but this really provides great insights into the factors driving these successes of the success of the Intercare program. And that this can also inform, as next steps, this has actually informed the adaptation for the next round of the study in preparation for scaling up of this particular program throughout Botswana. So now let's look at the other direction. So high income to low income and then back, which really is exemplified in the work from colleagues at the University of Washington. So starting with the extra CVD care at the top left, this is a study in Ohio and North Carolina, which used the hybrid type 1 design to evaluate 4 main components, so the nurse-led care coordination, home blood pressure monitoring, evidence-based treatment guidelines, electronic health record tools. Some of these strategies then informed their Palooza study, which is the one on the right, in Uganda, where they targeted urban and peri-urban regions in Uganda. And then they used human-centered design approach to adapt the strategies to improve hypertension care within HIV clinics. So this included providing access to medication, blood pressure machines, using what we call the differentiated service delivery model, which I would introduce in the next slide, in the subsequent slide. And also they used the remote patients monitoring to ensure that their patients were adhering to and to monitor their blood pressure control over time. So more recently, which is back again in the US, the Grow Rural study leveraged insights from the Palooza study in Uganda and another study in Brazil, which is not shown here. Again, using human-centered design approach to adapt the differentiated service delivery and remote patient monitoring from the Uganda study, and implementing this in rural regions of Mountain West and Pacific Northwest in the US. And they also use a hybrid type 3 design, meaning that they were focused mainly, their primary focus was really those implementation outcomes. And then they had secondary outcomes, which were their BP control and so on. So I share all of this, and by now it should sound familiar that some of these strategies are similar. And I share all of these studies to really show that bi-directional sort of flow of learning that goes on between high income, low income, and then low income to high income and back. So let's talk about the differentiated service delivery. And this is the last example I want to share. So this recognizes that care is not one size fits all, and is really designed to meet people where they are. So depending on the complexity, as you can see on your right, the right side image, so depending on the complexity of the severity of a person's condition. So services can actually be delivered flexibly. So either in the community or the facility. So this approach has been studied or scaled across African countries like Mozambique, South Africa, and has also shown to improve antiretroviral coverage and HIV outcomes. DSD is built on 4 main pillars, which I'll go into. So where, which is in yellow. So the where defines the location of services and levels of decentralization. So it could be in the community, at a community venue, and so on. And then the when defines the frequency and timing of services, whether it means that they will pick up medication on a bi-weekly basis, monthly basis, or bi-monthly basis, and so on. And then the who defines who is providing the services and the level of task sharing. So is it going to be delivered by community healthcare workers, pharmacists, nurses, and so on? And then the what, lastly, defines the package of services to be delivered. So tying this back to NCDs, hypertension care cascade data that I showed earlier has shown that the status quo service delivery may not always be enough. So DSD really offers that great opportunity to leverage lessons from HIV programs to improve hypertension diagnosis, linkage to treatments, and blood pressure control at scale. So another example, which is my last, this approach has been implemented in the US to improve hypertension care in barbershops. So in this model, barbers were trained. They were trained as lay healthcare workers. They were trained to measure blood pressure and then refer clients with elevated blood pressure to the closest clinic. So this result has actually been impressive. Blood pressure control improved in over 60% of participants compared with their control group, where 12%, they only had 12% of their participants with controlled blood pressure. Again, this demonstrates the potential for this type of strategy to be scaled for other NCDs. So now, this example I gave is barbershop. So it could be scaled across other faith-based organizations like churches, mosques, and so on, or specialty clinics. So to close out with some reflection, given the current landscape of resource limitation, as a field, we really need to, I will encourage us to consider what we call frugal innovation, where implementation strategies arising from LMICs like Nigeria, Uganda, Mozambique, South Africa, out of the need to do more with few resources. So our hope is that we can use implementation science to identify what supports are needed and the best ingredients for those type of supports in order to achieve that 30% reduction in mortality by year 2030. So there's this growing momentum for global to local learning that has fueled by networks such as HLB Simple, GACD. These collaborations really allows us to bring lessons from one setting, adapt them, and implement them in another setting. And perhaps might be that the guiding principle for our future, given the current situation and public health in general, could be that we should think globally and act locally. And with that, I would like to acknowledge the Havey Institute of Global Health for giving me this opportunity, and my mentors, Lisa, Sarah, my family, my husband's friends, colleagues, Amy, who really helped with my presentation, and then the members of the hypertension treatment in Nigeria team on the call, so from Northwestern, University of Abuja, and then WashU. And then lastly, acknowledge our funders, NHLBI. And with that, I would like to end and say thank you so much for listening. And
thank you so much, Chisom. Thanks so much, Chisom, for a really fantastic overview and really, again, highlighting that while problems may seem to be local, they're actually global. And I think that, this is this idea about how implementation science can help us bridge some of those gaps and really continue to learn from each other. So we have a couple of questions, and I would just encourage other people to shoot them into the Q&A because we do have some time. So Vincent from Botswana, Asathari, asked, was interested in this barbershop and was wondering if they were paid, and if so, how much? And maybe could talk a little bit more about that, and maybe even, since we have a little time, could could talk a little bit about this idea about how that sort of went from HIV to potentially hypertension and US to Africa and back again.
Yeah, no, thank you so much for that great question. So one of my master level mentors actually implemented a barbershop-led strategy here in New York. And I'm going to sort of use that as an example as well as this by Gbenga Ogedibe. And so the barbers were trained, they were compensated, and they were trained to sort of how do you then measure clients come in, but then you're creating awareness around hypertension, like this is a problem. You need to check your blood pressure, and then facilitating those blood pressure checks. And then they had sort of like a guide. So if they have elevated blood pressure, they would then refer to the closest community clinic or community center, whatever that may be. And so this idea of differentiated health services that was in HIV, so the HIV they've perfected it, right? So taking care away from the facilities, and they've done this with HIV self-testing, to be specific, where folks can actually do tests. They can test for HIV anywhere they want in the comfort of their home and then get the results. And if they're positive, then they go to the clinic. So this has been perfected in the HIV world. So then the idea is, how can we actually bring care outside the facility, which actually is one of my, I just wrote a grant, my K99, really understanding, can we engage young people in the communities, tell them about hypertension, and then go to places where they congregate, like schools or football pitch or barbershop. And then can we get them there and then test, evaluate their blood pressure. And if indeed that they're hypertensive, then we would then link them to the closest primary healthcare center. Leveraging some of those successes that we've done with the HCM program we did in Nigeria.
So Chisom, that's a perfect thing. Kylie, I'm going to come back to you, but Sahira, who is actually going to be our speaker next month, asks, fantastic talk, really informative to see this as a comprehensive implementation model for global South and North knowledge sharing. As a pediatrician and colleague of Chris Longnecker, I always wonder whether we have looked at some of these models to target young adults below 30 years of age. So I think this feeds very well into your approach, which Sahira, by the way, we also adapted, Chisom also adapted the status neutral approach. So maybe you want to talk a little bit about that, and particularly sort of how you're planning to adapt the strategies.
Yeah, no, that's a great question. So I'm going to talk a little bit sort of 360 overview of that. So there's this concept of what we call status neutral, where everyone gets engaged. So if you have normal blood pressure or elevated blood pressure, you're still going to get something. So for people with prevention, for younger people, we want to really find ways to prevent onset of hypertension and future CVD events. So why don't we then target them early and say, hey, maybe you should get on lifestyle counseling or watch your diet, the sodium you eat, and so on. So really catching them early before it progresses. And that's the idea of the status neutral. So not only focusing on the treatment aspect, but also how do we prevent them from getting hypertension and future CVD. And that's really the premise of my K99, which is under review, by the way. So that has been perfected again from the HIV world. So how do we take successes and strategies that have been implemented in HIV to integrate hypertension care in the communities or clinics and so on?
Thanks so much for that. So Kylie asks, what did you find were the biggest challenges when applying LMIC programs and strategies to high-income contexts?
Wow, that's a great question. So from what I saw from several studies or reviews, one major thing was how services are billed, which in the US or in low-income countries, I'm going to use Nigeria, for example, it's oftentimes out of pockets. Although some areas are starting to integrate health insurance scheme, but overall it's oftentimes out of pockets. Now, which is different in high income countries where, there's insurance involved And then if you're going to engage community healthcare workers, who's going to pay for them, or who's going to pay them, and for how long and where? So those are the main problems that I've seen in studies that have used sort of strategies like task shifting with community healthcare workers, or implementing strategies for hypertension. So who's going to bill, or who's going to pay the cost of the community healthcare workers, or who's going to cover the cost of treatments? So those are the top two I can think about.
Yeah, thanks. I mean, I think it's a really interesting question because, for example, community health workers are not actually well established, whereas in some of the countries I know in which you're working and others, they're already integrated into a part of the health care system. For example, the community health extension workers in Nigeria. So they sort of have a one-up on us to try to figure out then how could that strategy be adapted and then implemented at that stage. So Roxana Garcia says, thank you so much for a wonderful presentation. Can you comment on how to leverage implementation science to improve adoption for acute, timely, or high-risk evidence-based interventions, such as procedures and surgical procedures? And Roxana, I happen to know, is a neurosurgeon and doing work in Peru. And so this is something where timeliness, which is a component of quality that often those of us in internal medicine don't focus on. So thinking about that for some of these sort of high risk evidence-based interventions.
Yeah, no, that's a great question. And I'll confess, I haven't really dabbled in the field of neurology, but what I can think of in terms of generally for increasing adoption would be training. So training is usually the first sort of line of action. So how do you train whoever is going to implement it? So for example, could it be lower cadre healthcare workers? So training them to implement a thing. And also fidelity checks. So that initial monitoring, so monitoring their performance, are they actually doing what the protocol said they're doing? So that's usually a very key one. So not just giving them that, hey, this is use this, but also monitoring them and supporting them along the way. So for example, in Nigeria, we use supportive supervision, whereby the members of the top study team and the cardiovascular disease unit at the University of Abuja would come in, would go to the clinic, conduct quarterly visits, do like checks at their the way they're recording data, and also they would then shadow them to see how well they're taking blood pressure and so on. So having those sort of monitoring, supervision type of strategies are always very useful for adoption.
Yeah, no, I would agree. I mean, I think one of the other questions is what's the delay? So, we know that in trauma, there's a golden hour. We know it's sort of similar for other things as well. And so I think one of the things that implementation science allows also is to look outside of the really important areas that you're talking about, to think about, well, how long does it take somebody to come in and, adapting? There's something called the 3 delays for maternal care, which I think is a really important thing as well. If there's somebody else that's saying, okay, what role do you see community health workers playing in the U.S. healthcare going forward? Do you think U.S. will adopt community health workers as is done in countries like Nigeria? And I might add my own little twist to that. And what kind of evidence do you think we need to convince insurers in the U.S. that this is something they should pay for?
Yes, so I didn't show that example. I wish I did. But there's very far back in 1995, there was Costa Rica implemented a reform of their entire primary healthcare system. And what they did like an overhaul. One of the main successes of their program was that they implemented the community health worker strategy, whereby they know the community, they know who to talk to, they're more in touch with the community, they understand the language, the culture, and so on. So they really engage them to go out, do the blood pressure check, and bring people to the clinic. And that worked. And from what I've seen this in the literature, a lot of studies have actually modeled the successes of the Costa Rican study, including the US. So I also saw a paper recently that sort of adapted those the successes from the Costa Rican study that implemented community healthcare worker strategy. So I think it's starting to gain momentum. And then because they're called community, but community healthcare workers can actually also include the barbers, for example. And more recently, there's a circle study in Chicago that is using faith-based organizations to integrate hypertension care, and they're using faith-based leaders to encourage folks to get hypertension checks and also to refer. So those would also categorize as community, as long as you're trained to do the thing. So it's usually how is it defined and who are those community healthcare workers? Because initially when I heard community, I always would think about, oh, they're sort of like physicians and so on, but they could mean, depending on what you're trying to do, it could mean that you're training people such as faith-based leaders or barbershops, like I mentioned, or barbers rather, to implement hypertension care programs and so on. I hope that answers your question.
Yeah, thanks, Chisom. I have to say it's been a long-standing debate, and there's some global to local that's happened in the South Bronx. So a community health worker program in Togo, but the difference was instead of having them provide care like malaria treatment, not so much of an issue in the South Bronx, they focus a little bit more on things like social needs and adherence to care and getting people into care. And I think, I think the challenge is how do we do the costing to show the benefit so that insurance companies are willing to pay for that type of approach. So I'm going to send out one last call for any questions. And if not, I guess my last question to you is, Chisom, as you know, this was sponsored by, and I'm the director of the Ryan Family Center for Global Primary Care. And often people don't think of non-communicable diseases like hypertension as a part of primary care. And I'm wondering, when you're thinking about this concept of integration, how can implementation science help as we start to think about different models of integration?
Yeah, no, thank you for that question. It's sad because, like I mentioned, primary care is the bedrock of the health systems in general. So the best or the normal or how do I put it? The usual way, like the way it should be done, is that people should get hypertension or blood pressure checks. Like that should be the usual care. But then you find out that in places like LMICs, it's not being done. So this model of integration is really, how do you then change the conditions? Like, how do you train people, build capacity within this primary healthcare, or maybe give them treatment guidelines to understand, when do I treat, when do I refer, and so on. So changing the context and building capacity within the clinics to be able to implement those hypertension care strategies and so on.
Great, thank you. We have another one from an anonymous attendee. How should research projects that didn't start out with, I'm going to assume it's with implementation research as a goal, or perhaps, an effectiveness as a goal, how can that be added into their work?
Yes, that's a great question. I often get that from students. So if you started off by, say, you went to the community to evaluate fixed dose combination medication, for example, is it you want to see if it's increased blood pressure blood pressure control? You can actually add an implementation question and understand, so what exactly is helping them to achieve that effectiveness, or what's helping them to make it more acceptable, or what's going to help them to make this medication more for them to continue to use it over time and not just one time point. So the sustainability. So those are areas where you can actually tie in implementation science question, and you can do that through interviews. So through qualitative interviews, and maybe either at the start of your study or at the end, to understand those implementation science outcome. So that's one way to do it.
Great, thank you. So Rob, before we bring this to a close, I'm going to give you the chance for the last question, if you'd like.
Thank you very much for the kind of presentation. And it's really, I think, the unique thing, this local global thing. I was never a big believer in that, just to admit. But the more it goes on and the more work being done, the more it does seem like we have a lot to exchange. And do you see this getting more integrated, or is this really going to be very limited? I don't know. Lisa, you kind of touched on it because of the, who's paying. The insurers, right now are not paying. They don't even pay relative caregivers, let alone community health workers.
Yeah, I see this, honestly, I see this as what we hopefully should do more. So one community healthcare worker is one strategy, and there are many others that we can learn from LMICs to integrate here in the US. And like I said, the whole idea is to, given this resource constraints in this day and age, we really need to be focusing on how can we get things that work in the most cost-effective way. That's a big question. And that's where I see this whole idea of reciprocal innovation really come in. So taking things that have been established in US, for example, to LMIC and LMICs to back. And it came from the business world, but initially it was called reverse innovation. But then we needed to step away from that because that was very one-sided. So it was one way, going from high income to low income. But we've recognized that we can also be innovators in low income countries, and how can what we do inform other people globally? And I hope that answers your question.
Yeah, it does. I have a personal experience with people living in Spain, and they had a child who was severely disabled. And instead of getting outside people coming in, they actually basically put the mother on like a disability payment schedule so that she would have all the time to be the primary caregiver. I had never heard of that before, but that's just an example of how some countries handle it. I don't know if that's ever going to happen here, but
Yeah, I think it's a little bit of a challenge to us as researchers to understand what is the evidence needed to change the approach, and it's probably going to something to do with cost and cost savings more than anything else. So I want to thank the audience for the really wonderful questions. Obviously, very much want to thank you, Chisom, for sharing your insight and expertise. And I just want to invite everyone to join us at our next Institute of Global Health seminar, which is taking place virtually via Zoom on Wednesday, October 1st. This will be updates in pediatric HIV. Where are we now? Which will be presented by Zahir Jarjal Fargo, Associate Professor of Pediatrics in the Division of Infectious Disease and co-director of the Center for Global Pediatric Health at the Havey Institute for Global Health. You can register via our newsletter, Plant Purple, or our social media pages. Again, thanks for joining us. Please just again encourage for those of you who are not members to join, and you're very welcome to join the Ryan Family Center for Global Primary Care. And finally, a recording of the webinar will be available online and shared via our newsletter. And this concludes our webinar. So thank you all very much.
Thank you again, Chisom, for joining us today.
Thank you for having me.
Bye.
Bye.